Look at the clavicles and scapular edges on this PA film. Now let's look at the AP. Do you see any differences? Notice how the AP projection, the borders of the scapulae are sharp and appear to lie over everything else, while the clavicles appear to be obscured by the ribs and other structures. Also notice that the heart appears abnormally wide. Secondly, you want to know the position of the patient. Are they upright or lying? Again, hopefully this information is available. If not, in an upright patient you might see a fluid level in the stomach. 3. Check if the film is technically adequate. A useful mnemonic to remember the three aspects of technical quality is RIP. Rotation, inspiration, penetration. To check rotation, look at the clavicular heads and spinous processes. If the spinous processes are halfway between the clavicular heads, the patient is normally rotated. Next, check for adequate inspiration by looking at the midclavicular line and seeing which anterior rib intersects the diaphragm at this point. It should normally be the 5th, 6th or 7th. More ribs means the lungs are hyperinflated, often seen in COPD. Less means that the patient may not have taken in a full breath when the X-ray was taken. Finally, check the penetration of the rays. Simply put, an over-penetrated film is too dark, an under-penetrated one is too white. A trick to judge penetration is to look in the region of the heart. If you can see the spaces between the vertebrae and pulmonary vessels through the heart, penetration is adequate. This diagram shows how the X-rays travel through these structures, with the heart on the left, a pulmonary vessel in the middle, and the spine on the right. In an under-penetrated film, the weak X-rays fail to penetrate even the soft tissue of the heart, meaning the heart appears just as white as bone. In an over-penetrated film, the powerful X-rays go straight through the small, soft pulmonary vessels as if they weren't even there, making them invisible, while the heart appears darker than it should. 4. Look at the big picture. When you're examining a patient, you observe the whole patient from the end of the bed before delving into small details, and it's the same with examining a piece of imaging. Look at the whole thing. Can you immediately see any obvious abnormalities, like a large lung mass? 5. Now we want to start looking at the details. There are many different systems that people use to do this, and you may find your own that works for you. But the most commonly used system is the alphabetic approach, as it's easy to remember, and this way you're unlikely to miss anything, as long as you remember the letters A, B, C, D, E, F, G, H, I. Now let's start with A, which stands for airway. A normal airway is central and open. An airway that deviates to one side may be due to a tension pneumothorax. B stands for bones. With bones, start at the top and work your way down, making sure that you look at all the bones visible on the film. The outlines of each bone should have a smooth contour, and a break in the contour could be a subtle indication of a fracture. Also look for any lesions where the bone is more or less dense than it should be, such as the punched out lesions often seen in multiple myeloma. Whilst looking at the bones, you should also look at the external soft tissue for any abnormalities. C is the cardiac silhouette. On a PA film, the heart should be less than half of the chest width. An enlarged cardiac silhouette is most commonly